Hello everyone, I'm Dr. Rohan Khandelwal. I'm your marrow surgery faculty, and today in this video I'll be talking about the December surgery 2021 FMG recall. Now this FMG exam in December was a very clinical exam, and there were lots and lots of questions from surgery. Almost 40 plus questions from surgery were there. So going forward also, the FMG exams will have a clinical bent to them, and there will be more focus on the clinical subjects. So without wasting any time, let's discuss the surgery questions which were asked in this FMG exam. You know, a lot of questions in surgery get repeated, so it's very important that you go through this video even before your next FMG exam. So moving on to the questions, the first question was that after resecting a lipoma over the neck, a patient develops a scar with itching, right? So there's a scar with itching there. The elevation is restricted to the region of the scar. This is a very important line. The elevation is restricted to the region of the scar. What is the most likely diagnosis? Now you know that if there is a raised red itchy scar, there are two diagnoses. There can either be a hypertrophic scar or there can be a keloid. But the fact that the scar or this area is restricted to the region of the scar, this clearly points towards a hypertrophic scar. If it was beyond the region of the scar, it would have been a keloid. So you can see the images have also been asked in the exam. Keloids grow beyond the boundary of the scar. You can see this is growing beyond the boundary of the scar, whereas hypertrophic scar is restricted within the boundary. So if you have to go through over the differences, keloid will go beyond the boundary, whereas hypertrophic scar will remain within the boundary of the scar. Both can be red raised itchy scars. Now keloid does not settle with time and pressure, whereas a hypertrophic scar will settle with time and pressure. For keloids, sternal region is the most common region. Other regions are the shoulder and the ear lobules, whereas extensor surfaces are commonly involved in hypertrophic scars. Keloids are also more common in dark-skinned patients, and the management is intralesional triamcinolone or intralesional steroids. This has also been asked in the exam. You should know about it. The next question, and invariably there are scenarios regarding head injury which are asked in every exam, and this exam was no exception. There were at least two scenarios related to head injury in this FMG exam. The first question was a 54-year-old lady meets with a road traffic accident after traveling back from her office. Which of the following is most commonly associated with the lucid interval? So rather than giving a detailed history or a CT scan, they've asked which head injury is most commonly associated with a lucid interval. So most commonly it is extradural hemorrhage or EDH. EDH or extradural hemorrhage is most commonly associated with a lucid interval. Now mind you, lucid intervals can be seen in any head injury, but they are most common with extradural hemorrhage. Extradural hematoma, commonly occurs in young patients following a high velocity impact. The bleeding is mainly arterial in nature, and the vessel implicated is the middle meningeal artery. This has also been asked in the exam. You commonly see a lucid interval. Lucid interval, is the period of normal consciousness between two episodes of unconsciousness. So normal consciousness between two episodes of unconsciousness is the lucid interval. The investigation of choice for head injury is NCCT, and we'll do a burr hole to drain this out. On NCCT, on extradural hemorrhage, and this has also been asked many times in the exam, you get a biconvex or a lens-shaped hemorrhage. Subdural hemorrhage is commonly seen in elderly patients, and this has a more gradual presentation. The patient after a trivial trauma will come with altered sensorium after a few weeks. The bleeding here is mainly venous in nature because of the bridging veins, and here you get a concavo-convex or a crescenteric hemorrhage in subdural hematomas. This was also asked in the last to last year exam. Most severe head injury is diffuse axonal injury, and diffuse axonal injury, there is shearing force between the grey and the white matter. The patient is in a state of coma, but NCCT is normal. The investigation of choice is MRI, and the sign that you get is punctate hemorrhages at the grey and white matter junction. This has the worst prognosis amongst all head injuries. The next scenario is a young male develops hypertension and bradycardia after road traffic accident, and on the CT he is diagnosed to have cerebral edema. What is the most likely treatment? So you know, when there is head injury and there is raised intracranial tension, there can be Cushing's reflex. And what is Cushing's reflex? Cushing's reflex, you know, is hypertension, it is bradycardia and altered respiration. So hypertension, bradycardia and altered respiration is Cushing's reflex, which can be seen in head injury. Now when you have raised intracranial tension, how do we manage it in head injury patients? Well, we usually give mannitol. Mannitol is an hypertonic solution which will reduce the cerebral edema. Right? Mannitol is hypertonic and it will reduce the cerebral edema. Steroids, and I mentioned this many times in my lectures, steroids have no role. Steroids have no role in raised ICT due to head injury. Steroids have no role in raised ICT due to head injury. Steroids can be used in those patients where there is raised ICT because of a tumor in the brain. But following road traffic accidents, steroids have no role. Okay? So we'll use mannitol, that is what is used. Another question, and this is a repeat question asked previously as well, battle sign is seen in. So we know battle sign is a sign of middle cranial fossa fractures, which is seen in petrous part, the temporal bone is fractured. Right, so battle sign is discoloration over the mastoid process. You can see here, this is seen in middle cranial fossa fractures when there is fracture of the petrous part of the temporal bone. You can also get raccoon eyes, but raccoon eyes are seen in anterior cranial fossa fractures, right? Black eyes or raccoon eyes and CSF rhinorrhea will be seen in anterior cranial fossa fractures, whereas middle cranial fossa fractures you will get battle sign and you can get CSF otorrhea. CSF otorrhea, you know, is CSF coming out through the ear. The next question was, a patient comes to the emergency room with the worst headache of life. I guess just with these keywords you can make the diagnosis, worst headache of life, and they're given a CT image as well. The CT image is somehow missing here, but they're given a CT image, but just with this worst headache of life, you can make out it's a subarachnoid hemorrhage. So subarachnoid hemorrhage, patient will come with the worst headache of life, and this can be diagnosed on a CT scan. You can diagnose this because there will be bleeding along the Sylvian fissure. A patient following a road traffic accident has a blood pressure of 80 by 60 millimeters of mercury. Fast scan is positive. What is the next step in the management of this patient? Now we know when there is a patient who is unstable, and we are suspecting abdominal injury, and in this patient we are suspecting abdominal injury. So in this patient, the investigation for an unstable patient will be FAST, right? And FAST, the full form has also been asked in the exam. FAST stands for Focused Assessment Sonogram in Trauma. So this is Focused Assessment Sonogram in Trauma. And in FAST, we keep the probe at 4 places. The first in the epigastrium. Second place where we keep the ultrasound probe is right hypochondrium. Third is left hypochondrium, and fourth is pelvis. So 4 places we keep the ultrasound probe, that is known as FAST. E-FAST is extended FAST, when in addition to these 4 places, the probe is also kept in the right and the left thoracic cavity to look for any collection or abnormality in the thorax. Now here the patient has a fast positive. So if fast is positive in an unstable patient, we will take up the patient immediately for an exploratory laparotomy to see where is the problem in the abdomen and we will address it. Okay, so unstable patients we do fast, stable patients we do CECT. If fast is positive, take up the patient for laparotomy. A young patient is brought to the emergency room with complaints of hypotension, distended neck veins and muffled heart sounds. Patient dies in the ER and an autopsy is performed. What is the most likely cause of death? So well, very distinct keywords here: hypotension, distended neck veins and muffled heart sounds. All these are signs of Beck's triad, which is seen in cardiac tamponade. So these 3 are part of Beck's triad, which is classically seen in patients with cardiac tamponade. Cardiac tamponade is when there is collection of blood around the heart and that leads to impaired cardiac function. So this can be seen in trauma. Beck's triad is hypotension, raised JVP and muffled heart sounds. The emergency management is needle pericardiocentesis, where you insert a needle, drain out some blood. The definitive management is to carry out a thoracotomy. You make a thoracic incision, a thoracotomy, and you create a pericardial window. This is what tamponade looks like on fast scan. You can see here that there is collection around the heart. So this is a sign of cardiac tamponade. This is a sign of cardiac tamponade, and I've already told you about Beck's triad. So you know, almost every year either cardiac tamponade is asked in the exam or tension pneumothorax is asked. In the previous exam, tension pneumothorax was asked. In this exam, they've asked about cardiac tamponade. There were few questions regarding shock as well. I've already re-emphasized that shock is a very important topic. At least 2 to 3 questions every year are there from shock. Now a patient is brought to the emergency room following road traffic accident and has hypotension and cold clammy skin. So hypotension means patient is losing blood, that is why there is hypotension and there's cold clammy skin. So this can only be seen in hypovolemic shock. Very straightforward, it will be seen in hypovolemic shock. You know, in hypovolemic shock, the pulse rate, there is tachycardia. There is hypotension in the later stages. From stage 3 onwards, there is hypotension. Cardiac output will be reduced. The extremities will be cold and the JVP will be raised. The JVP will be low because the body is losing blood. JVP will be low because the body is losing blood. Whereas in cardiac tamponade, the pulse rate can be high or low. BP will be low because heart is not functioning. And because the heart is not functioning, the JVP will be raised in these patients. In neurogenic shock or spinal cord injury, very important question which has been asked, there is bradycardia and hypotension and there will be warm extremities. Bradycardia, hypotension and there will be warm extremities. Anaphylactic shock, there will be warm extremities, there will be tachycardia. Right? There will be tachycardia in anaphylactic shock. 2 questions which have been asked many times. The best indicator to determine amount of fluid required in a patient with shock, and this was asked in the FMGE exam 2 years back. It is pulmonary capillary wedge pressure. It is pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure is the best indicator, better than central venous pressure. Now practically, we always measure the central venous pressure, but theoretically, if pulmonary capillary wedge pressure is given in the options, you will have to mark that as well. The best indicator of fluid resuscitation in shock is urine output. is urine output. Both these questions have been asked multiple times in the exam. Now you have another patient who has cirrhosis and portal hypertension, and this patient undergoes endoscopy and is found to have esophageal varices. A few days later, she develops melena and has a repeat bleed, right? She dies because of this melena and has a bleed. What is the likely cause of her death? Well, you know these varices can rupture, and if these varices rupture, they can give rise to upper GI hemorrhage. So this patient has died because of hemorrhage, and that will lead to hypovolemic shock. So yes, varices have bled, but what is the cause of death? The cause of death is hypovolemia or hemorrhagic shock. So this was a very straightforward question which was also asked. You have a patient who comes with road traffic accident. His GCS is 10/15 and there is hypotension present. Hypotension does not improve after fluids, right? So of course patient is losing blood somewhere, right? So even after giving fluids, the hypotension is not improving. So what is the least likely cause of this condition? That was the catch in the question. They did not ask what is the cause. They asked least likely. So whenever the patient is hypotensive, we say that there can be blood which can be on the floor. That means there is external injury, or it can be there in the neck, or it can be there in the thorax, or it can be there in the abdomen, it can be there in the pelvis, it can be there in the retroperitoneum, or because of long bone injury. So these are the reasons why the patient can have hypotension. There can be bleeding and hypovolemic shock. But let's look at the options now. Splenic rupture, yes, it can give rise to it. Hemothorax, yes. Pelvic fracture, yes. But isolated head injury, there is not enough space in the head for the patient to go into hypovolemia, right? So subdural hematoma alone will not cause hypotension in these patients. While inserting a central venous line through the subclavian vein, patient develops sudden breathlessness and absent breath sounds on the right side. What is the most likely cause? I've told you again and again that whenever we put a central line, and especially through the subclavian route, there is a risk of pneumothorax. Okay. So the answer here will be pneumothorax, and that is why now that when you do your internship, or when you're seeing a patient after a central line, you will always be told that get a chest x-ray done. Why do we want to get a chest x-ray done? To rule out pneumothorax and to see where the tip of the central line is lying. Okay? And maximum risk of pneumothorax is with subclavian lines. Maximum risk is with subclavian central lines. But what is the most common vein for central lines? This question was asked in your last exam. The answer is internal jugular vein. Okay, internal jugular is the most common vein used, but subclavian veins can be associated with pneumothorax. Now, bed sores will be formed where the pressure is constantly above 30 millimeters of mercury. This is also the pressure for compartment syndrome. So both is 30 millimeters of mercury, compartment syndrome also, and for pressure sores or bed sores, it is both is 30 millimeters of mercury. Ischium is the most common site for pressure sores. This has also been asked. Ischium is the most common site for bed sores, and bed sores can be prevented by frequent change of position. So we can prevent bed sores by frequent change of position or by using an air or a water mattress. This was a new question for the FMGE exam. This was being asked in the PG exam. Which of the following breast cancers has the best prognosis? The answer here is luminal A. This is based on the molecular classification of breast cancer. This is the molecular classification of breast cancer. And you should know that the molecular classification of breast cancer, we take into account ER, that is estrogen receptors, PR, that is progesterone receptors, HER2 neu, and Ki67. What is Ki67? Ki67 is a proliferation index marker. Ki67 is a proliferation index marker. This tells us how quickly the tumor is multiplying. Okay, so I want you to remember for FMG, I want you to remember just the basics, that luminal A type, this is the most common and this has the best prognosis. So these two questions have been asked multiple times. Luminal A is most common and it has best prognosis, and it is ER/PR positive, HER2 neu negative. Luminal B can be ER/PR positive, HER2 neu negative, but high Ki67 will be there. Or it can be triple positive. HER2 neu enriched is when HER2 neu is positive and ER/PR is negative. And basal-like is triple negative. Okay, basal-like is triple negative. So this is also very important. This basal-like is also known as triple negative. And probably they can ask this next time, that triple negative has the worst prognosis. So luminal A has the best prognosis, whereas triple negative breast cancer has the worst prognosis amongst all breast cancers. So you should know this for your exam, for future exams as well. Now, a 35-year-old lady comes with a single mobile lump in the breast, which measures 2 into 2 centimeters. Okay, single mobile lump. Now the key here is mobile. It has firm consistency. Family history of breast cancer was present. What is the management? So there is a mobile lump 2 into 2 centimeters. You know, mobile lumps are commonly fibroadenomas. Fibroadenoma is the most common benign lump. It is the most common benign lump. It is also known as a breast mouse because it keeps on moving. We call it a breast mouse. This question has also been asked. And on mammogram you can see popcorn calcification. You can see popcorn calcification in a fibroadenoma. Now, if there is a 2 into 2 centimeter fibroadenoma, how do we manage it? So, what are the indications for surgery in a fibroadenoma? So fibroadenoma excision are done if there is a family history of cancer, like in the patient, or if the size is more than 5 centimeters, this is known as a giant fibroadenoma, or if there is pain, if there is increase in size, or if it is a cosmetic indication. These are the indications to remove fibroadenomas. Now in this patient, there is a family history of breast cancer, which is why we have to carry out excision in these patients. Now excision for these patients can either be done via the open method, or one new thing which I want to tell you, which I am doing routinely. In fact, in India I have the largest number of cases for this technique. This is known as VAB, or scarless breast surgery. VAB or scarless breast surgery. So this is known as vacuum assisted breast surgery, right? Vacuum assisted breast surgery. You can see this was a girl with bilateral fibroadenomas and we've removed them. There's hardly any scar present, right? So this is scarless breast surgery, which is done for fibroadenomas. So the next question is that after 3 days after delivery, a 25-year-old presents with a tender, fluctuant 2 centimeter lump in the right breast. On ultrasound, collection is present in this mass. what is the most appropriate management? So very obviously the hints given here are that there has been a delivery, the patient would be lactating, and a lactating lady comes with a tender fluctuant mass in the right breast. Now this tender fluctuant mass on the right breast is most likely to be an abscess. And how do we manage an abscess? Abscess would be incision and drainage. When there's already pus there, when there's a collection there, we have to carry out an incision and drainage. It would look something like this, where there will be a tender fluctuant mass, and for these patients we will carry out, for these patients what would be done is that it would be drained using an incision and drainage. You know, breast abscesses, the most common organism is Staphylococcus aureus, and the source is the oropharynx of the child. It comes with a painful tender lump. Diagnosis is by ultrasound. Another question which has been asked in the exam, that amoxicillin plus clavulanic acid is the most frequently used antibiotic in such patients, and we try aspiration. If aspiration fails, we carry out an incision and drainage in these patients. A 25-year-old presents with hypertension and with profuse sweating and headache. What investigation should be ordered in these patients? So hypertension, sweating, headache, all of these are signs of pheochromocytoma. All are signs of pheochromocytoma. Now you know that pheochromocytoma, to diagnose a pheochromocytoma, the initial investigation would be 24-hour urinary VMA and metanephrines. VMA is vinyl mandelic acid. VMA is vinyl mandelic acid, and metanephrines. This is what we will do initially. So pheochromocytomas, headache is the most common symptom, hypertension is the most common sign, and majority of this times this hypertension is episodic. The screening test is 24-hour urinary VMA or metanephrines, and the most sensitive test to diagnose pheochromocytoma is plasma-free metanephrines. On cut section, pheochromocytoma appears tan brown in color. MRI is the investigation of choice, the imaging investigation. MRI is the imaging investigation of choice, and this has also been asked. You get the light bulb sign on MRI. If you have an extra adrenal pheochromocytoma, then the investigation is a gallium dotatate scan. This is what a light bulb sign looks like on MRI. You can see here, this is the light bulb sign this is the light bulb sign which you see on MRI in patients with pheochromocytoma. The next question regarding endocrine surgery was that a 30-year-old male complains of cold intolerance, lethargy and weakness, and the thyroid function test for this patient is done and TSH is raised. We know that this patient has cold intolerance, lethargy and weakness, and these are all signs of hypothyroidism. These are all signs of hypothyroidism, right? And TSH is also raised, which is also a sign of hypothyroidism. So what would be the most appropriate management? So we know that we give levothyroxine. Any patient who is hypothyroid, we give levothyroxine, and we always start with the minimum possible dose and we gradually build it up, right? So if you go to any endocrinologist, they'll start the patient on the minimum possible dose and they'll gradually build it up. So levothyroxine 25 micrograms and then increase the dose gradually. That is what is done in such patients, and you keep on titrating it with the TSH values and you observe the symptoms, and when the TSH values come to the normal range, that is the right dose of thyroxine for this patient. So moving on to the GI questions, invariably there are 2 or 3 questions from gallbladder. That has been the trend in the last few exams. A patient undergoes a lap cholecystectomy and is discharged the next day. She comes back after 2 days with pain in the right hypochondrium. Liver function is normal, but total leukocyte count is raised. What is the most likely problem in this patient? So she's had a lap chole and 2 days later she comes with pain in the right hypochondrium and LFT is normal but the TLC is raised. All these are signs of a bile duct leak, right? Bile leak will present as this, and to diagnose this bile leak, we will do MRCP. What is MRCP? MRCP is magnetic resonance cholangiopancreatography. So magnetic resonance cholangiopancreatography is done in these patients. A 28-year-old lady is diagnosed with, so one more thing which I want to tell you, why can't it be a CBD stone? Why isn't it a CBD stone? Because if it was CBD stone, there will be features of obstructive jaundice. That means there would have been raised serum bilirubin, there would have been raised serum ALP. But they have mentioned here that liver function tests are normal. So that is how you can differentiate the two conditions. Now you have a 28-year-old lady who is diagnosed with an incidental GB polyp which measures 5 millimeters. Patient is asymptomatic. What is the most appropriate management for this patient? Now we have read that GB polyps can be associated with cancer, but not all GB polyps require immediate cholecystectomy, right? So if the GB polyp is asymptomatic, and if it is less than 1 centimeter in size or 10 millimeters, then we will keep the patient under observation, right? Then we keep on doing observation. So I also have a GB polyp and it is 6 millimeters. So all I do is every 3 months I will just get an ultrasound done. I don't do anything else, just get an ultrasound done every 3 months. That is what is done. But if the GB polyp is more than 1 centimeter or it is symptomatic, then we will do lap chole in these patients. Right? So here the treatment is going to be observation because the polyp size is just 5 millimeters. One more question asked previously in the exam was that gallstones will cast a post-acoustic shadow. There will be a shadow which will be casted whenever you have a stone. But when you have a polyp, there will be no post-acoustic shadow. In a polyp, there is no post-acoustic shadow. So that is how you can differentiate the two conditions. What do you expect in a patient who has undergone lap cholecystectomy? So lap cholecystectomy, what findings do we expect in that patient? Now we've removed the gallbladder and the gallbladder has bile in it. And you know that bile is required for fat emulsification, right? Bile is required for fat emulsification. So some patients where the gallbladder is removed, fat is not properly emulsified and fat is not properly absorbed. So this fat would be eliminated in the stools and that is known as steatorrhea. So some patients who've had their gallbladder removed can have steatorrhea. Now you have a 35-year-old male who comes with upper abdominal pain to the emergency room. Patient has pain radiating to the back. So pain is radiating to the back. On X-ray, colon cutoff sign is seen. So pain in the epigastrium radiating to the back. These are all features of acute pancreatitis. And in acute pancreatitis, there are certain non-specific X-ray signs. And what are these non-specific X-ray signs? You have colon cutoff sign. You have sentinel loop sign. And you can have gasless abdomen. And all these three signs are basically representing ileus. Ileus means the bowel is not contracting. Why? Because of inflammation. So because of inflammation, there is ileus, the bowel is not contracting, and you will get these non-specific signs in acute pancreatitis. This was a very straightforward question. You had a 45-year-old female who'd come to the OPD with complaints of dysphagia and intermittent chest pain. Barium swallow is done and the image is shown below. What is the diagnosis? So this barium swallow, you can see you get the rosary bead appearance. You get rosary bead appearance, right? And this rosary bead or corkscrew appearance is typically seen in diffuse esophageal spasm. Diffuse esophageal spasm or corkscrew esophagus, that is where you get it. The new name for diffuse esophageal spasm is distal esophageal spasm now. The new term is distal esophageal spasm. For achalasia, you get the bird's beak appearance, and for cancer, you get the rat tail appearance. I will show you the bariums for both of them, so you don't need to get confused. This is the typical rosary bead or corkscrew appearance, which you can get in patients with diffuse esophageal spasm. This is achalasia. Achalasia is gradual tapering, and this is known as the bird's beak appearance. This is known as the bird's beak appearance. Whereas cancer, you have abrupt narrowing. This is known as the rat tail appearance, or ragged edges are there. This is a constant question in every exam. You have a 45-year-old male with a history of NSAID consumption. The patient comes to the emergency with severe abdominal pain. There is tachycardia, hypotension and rebound tenderness, and you're shown an X-ray, right? So what is there? In this X-ray, you can see that there is gas under the diaphragm. There is gas under diaphragm. And when do we get gas under the diaphragm? We get gas under the diaphragm when there is a hollow viscous perforation. When there is a hollow viscous perforation. And what is the other hint in this question for hollow viscous perforation? Because you have NSAID consumption, so that can give rise to a peptic ulcer which can perforate, and the signs of peritonitis are rebound tenderness, guarding, rigidity, rebound tenderness are all signs of peritonitis. So if you have any patient with peritonitis, we will have to do immediate laparotomy to look for the cause. This was a repeat question from last time. A baby playing unsupervised complains of difficulty in swallowing. Now in the question itself, they're saying difficulty in swallowing. X-ray is done and you see a coin. Now you can very clearly see in this X-ray that you can see the tracheal gas shadow in front, and the coin is behind the tracheal gas shadow. So if the coin is behind the tracheal gas shadow, it will be a foreign body in the esophagus, which you can anyways figure out just from the question when they said that there is difficulty in swallowing. So one tip for the FMG exam is that they will give you multiple hints. There will be hints in the X-ray, there will be hints in the question stem, and if you can pick up these hints, you can get to the answer using both of them or one of them as well. So just look for these hints and you can get to the correct answer. Foreign bodies in the esophagus, most commonly they get lodged in the C6, that is the pharyngoesophageal junction, that is the narrowest portion of the gastrointestinal tract. This is 15 centimeters from the upper incisor. The two other constrictions are 25 and 40 centimeters from the upper incisor. 15 is the pharyngoesophageal junction, 25 is the left main stem bronchus, and 40 centimeters is when the esophagus pierces the diaphragm. The next question is, the 45-year-old female undergoes total gastrectomy 6 to 7 years back and now complains of anemia with neurological symptoms. So what type of anemia is most common in this patient? So we know after gastrectomy, iron deficiency anemia is most common, right? But here in this question, they are saying that there are neurological symptoms also. and this patient had a total gastrectomy. So when a total gastrectomy has been done, intrinsic factor deficiency will also be there, right? So this anemia and neurological symptoms is most likely because of megaloblastic anemia, which you will get with vitamin B12 deficiency also. Which you will get with vitamin B12 deficiency as well, right? So that this was a very good question. I would say this was a question which a lot of PG candidates would also have made a mistake in. So good question to ask. A chronic liver disease patient comes with pain all over the abdomen. On examination, tenderness is present. Ascitic fluid reveals neutrophils which are more than 500 per cubic millimeter. What is the next best management? So this is the typical scenario. You know, chronic liver disease patients will have ascites, right? And these patients with ascites can undergo spontaneous bacterial peritonitis. There can be spontaneous bacterial peritonitis in these patients. Now this spontaneous bacterial peritonitis, when you do ascitic fluid tap, there should be more than 250 per cubic millimeter neutrophils which should be present. More than 250 per cubic millimeter of neutrophils should be present to make this diagnosis. And the most common organism in adults which is responsible for spontaneous bacterial peritonitis is E. coli. So in these patients, what they will require is broad spectrum IV antibiotics. So you will give IV antibiotics in these patients to tide over this problem. The next question is, a 7-month pregnant lady comes with pain in the right side of the abdomen. On ultrasound, acute appendicitis is diagnosed and a TLC count is raised. What is the next step in the management? So you know that acute appendicitis is the most common abdominal emergency in a pregnant lady, right? And if you have acute appendicitis in a pregnant lady, the chances of perforation are very high. So in these patients, we have to go for acute appendicectomy or emergency appendicectomy. We don't wait in these patients because the chances of perforation are high. Ochsner-Sherin regime is done when there is an appendicular lump. When there is an appendicular lump, that is when Ochsner-Sherin regime is done. But in this patient, there was acute appendicitis, so there is no role of Ochsner-Sherin regime. Ochsner-Sherin regime is the conservative management in a patient with an appendicular lump. Which of the following deficiencies seen when the terminal ileum is removed in a patient due to Crohn's? This is a very straightforward question. You know, terminal ileum is the place for absorption of vitamin B12, and these patients will come with vitamin B12 deficiency. A 36-year-old presents with passage of blood and mucus in the feces. On sigmoidoscopy, rectal inflammation is seen. On biopsy, crypt abscesses are seen. What is the diagnosis? Right, so we know that this is a patient of inflammatory bowel disease. Now there can be two types of inflammatory bowel disease. You can have ulcerative colitis and you can have Crohn's disease. In ulcerative colitis, there is continuous spread. There is continuous spread and rectum is commonly involved. Rectum commonly involved. In Crohn's disease, we know there are skip lesions and there is relative rectal sparing. There is relative rectal sparing in patients with Crohn's disease. Okay. Now, ulcerative colitis, when we do the biopsy, you will see crypt abscesses. You can see crypt abscesses in ulcerative colitis. Whereas in Crohn's disease, you can see non-caseating granulomas. You can see non-caseating granulomas. So here it is clearly mentioned that the rectal inflammation is seen and biopsy you see crypt abscesses. So the diagnosis is going to be ulcerative colitis in this patient. Now there is a patient who is suffering from inflammatory bowel disease. He comes with peritonitis and perforation of the ileum. So we just discussed that when there is peritonitis, that means fecal matter has come into the peritoneal cavity, right? The entire abdomen is contaminated. Now we have to do emergency laparotomy in these patients. But when there is so much of contamination, I cannot do anastomosis because the anastomosis will not hold, because the patient's condition is not good and there is contamination. So in these patients, what we do is, when there is ileal perforation, there is contamination, we will create an ileostomy, right? Ileostomy is when we take out the ileum outside in the stomach wall, the fecal matter will come out from here for some time, and after a few weeks, we will go in and we will again do the anastomosis. But we don't do definitive anastomosis at this time because of the contamination present. A patient is taking broad spectrum antibiotics for a long time. Now the patient comes with diarrhea. What is the most likely organism? Now this patient has been on antibiotics for a long time. There is alteration of microbial flora, and this can give rise to pseudomembranous colitis, and the cause of pseudomembranous colitis is Clostridium difficile. This has been asked many times previously. Clostridium difficile is the most common cause of pseudomembranous colitis. Clostridium botulinum gives rise to, you get botulinum toxin from this organism. Clostridium perfringens gives rise to gas gangrene, and Clostridium tetani gives rise to tetanus. But Clostridium difficile is the one which causes pseudomembranous colitis, where there can be diarrhea after prolonged antibiotic therapy. A 3-day-old child is seen with greenish yellow discharge from the umbilicus. What is the most likely cause? So you know that there is a vitello-intestinal duct, right? There is a vitello-intestinal duct. Now this vitello-intestinal duct connects the ileum with the umbilicus, right? This vitello-intestinal duct connects the ileum with the umbilicus. Now if you have a patent vitello-intestinal duct, which is persistent from the ileum to the umbilicus, the patient will have fecal matter, right? Greenish yellow fecal matter which will come from the ileum to the umbilicus. Okay. Now if only the intestinal end is patent, or persistent, then this gives rise to Meckel's diverticulum, which has also been asked in the exam. If only the umbilical end is persistent, then this gives rise to a sinus where pus discharge can come from the umbilicus, but not greenish yellow fecal matter. If fecal matter is coming, then it is a persistent vitello-intestinal duct which is still communicating with the bowel, and fecal matter is coming out. Persistent urachus. Urachus is when the bladder communicates with the trachea, with the umbilicus. When the bladder communicates with the umbilicus, and in these patients what will happen, that whenever there is raised intra-abdominal pressure, some amount of urine will come out through the umbilicus. A 5-year-old child is brought with chronic constipation. After taking stool softeners, the patient is able to pass stools. Patient had delayed passage of meconium at birth, right? So delayed passage of meconium and chronic constipation, all these are signs of Hirschsprung's disease. Now majority of the Hirschsprung's disease will present during the initial few days with the non-passage of meconium. But some patients, like this patient, they can present later on in life as well with chronic constipation. So in this patient, how do we come to the diagnosis? We do barium enema and anal metometry, right? The best investigation is a rectal biopsy, which is a full thickness rectal biopsy, but that was not given in the options. So the next best to mark is a barium enema and anal manometry. In the anal manometry, there will be raised pressure. Now you can see in Hirschsprung's disease, you will get a picture like this when you do an enema. You will get a dilated loop and you will get a constricted loop, and this constricted loop lacks the ganglion cells. Constricted loop lacks ganglion cells which are absent in the constricted loop. But I have told you the best is a full thickness rectal biopsy. The internal opening in a fistula in ano usually begins from, so the crypt at dentate line is the correct answer, and to know this, you know a fistula is one which has an external opening and an internal opening. And this is the Parkes classification. According to the Parkes classification, intersphincteric fistulae are the most common. Now, intersphincteric fistula, if you look at the intersphincteric fistula, this is the dentate line here. These are the crypts at the dentate line. And majority of the intersphincteric fistulas will begin from here and will go between the sphincters. So, in majority of the fistulae, the internal opening starts close to these crypts, close to the dentate line, right? So most common internal opening will be close to the dentate line, because you know that these crypts are the site where infection starts. The next question was, just the wording was confusing, but this was a very simple question. A patient comes with herniation of intestinal loops that pass along with the spermatic cord and reach to the cremasteric muscle, right? What type of hernia is this? Now to understand this, you know the Hasselbalch's triangle. The Hasselbalch's triangle is bounded by the inferior epigastric vessel superiorly, by the inguinal ligament inferiorly, and by the outer border of rectus medially. This is the deep ring and this is the superficial ring, and through this comes your cord. Through this comes the spermatic cord, right? Now this hernia is coming along with the spermatic cord. So this is coming lateral to the Hasselbalch's triangle. And any hernia lateral to Hasselbalch's, any hernia lateral to Hasselbalch's is indirect hernia. Any hernia lateral to Hasselbalch's is indirect hernia. Any hernia which comes through the Hasselbalch's triangle will be a direct hernia. So if you see the question, herniation is along the spermatic cord, right? So because it is coming lateral to Hasselbalch's, it will be an indirect hernia. Moving on to the questions which are asked in urology. So you had a 47-year-old male who came with a renal mass involving the lower pole. So there is a renal mass involving the lower pole. What is the preferred treatment option? The renal mass is 7 into 4 into 2 centimeters. Now this is most likely a renal cell carcinoma. Renal cell carcinoma mainly involves the poles, that is the upper pole and the lower pole. And T1 is divided into T1A and T1B. T1B is till 4 centimeters in size and T1B is till 7 centimeters in size. That is T1B. Now this is a T1B lesion, and for all T1 lesions we can do partial nephrectomy. We can do partial nephrectomy if no contraindication is there. So for T1 we can do partial nephrectomy. That will be the correct answer here. For bigger lesions, we will do radical nephrectomy. For T2 lesions bigger than 7 centimeters, radical nephrectomy where the entire kidney is removed will be done. Very straightforward question. Most common type of renal stone, calcium oxalate. You know that calcium oxalate are the most common stones. They are radiopaque stones which are formed in acidic urine. Triple phosphate stones are formed in infected urine. They are because of Proteus. The most common radiolucent stones. So radiopaque means which can be seen on an X-ray. Radiolucent means which cannot be seen on X-ray. The most common radiolucent stones in the kidney are uric acid. But most common overall is calcium oxalate stone. An elderly male is detected with carcinoma of the prostate. On evaluation, metastasis is found. So this is metastatic prostatic cancer, metastatic prostate cancer. And we know in metastatic prostate cancer, the first line of treatment is androgen deprivation therapy. The first line of treatment is androgen deprivation therapy, right? We have to reduce the testosterone level. Now to reduce the testosterone level, either we can remove both the testes or we can give LHRH agonists like goserelin, buserelin or leuprolide along with anti-androgens. So if you look at the question, they are asking which of the following drugs can be used. So in this patient, leuprolide, which is an LHRH analog, this will be used in patients to reduce the testosterone levels, and this acts as hormonal therapy. A 5-year-old girl comes with continuous dribbling of urine with a normal voiding pattern as well. What is the most likely cause? This was a repeat question from last time, and the correct answer here is duplication of the uratric system, and this is based on the Weigert-Mayer's rule. The Weigert-Mayer's rule states that if there is duplication of the uratric system, the ureter which is draining the upper pole, this green ureter, will open more medially and more distally as compared to this ureter which is draining the middle and the lower pole, right? Which is draining the middle and the lower pole. This will drain normally into the bladder. The patient will pass urine normally. But this one which is draining distally, in females it can open in the vagina. So this girl will have continuous dribbling through the vagina, plus she can hold her urine as well because the normal ureter is opening in the bladder. So this is the typical history of duplication of the uratric system. Whittaker test, this was a new question. Whittaker test is done in patients with hydronephrosis. It is not done these days. So the next question is that a 5-month-old baby is brought to the OPD with bilateral undescended testis. What is the most appropriate treatment? So we know that bilateral undescended testis is known as cryptorchidism. Now we also know that we don't operate undescended testis till 6 months of age, right? Till 6 months there can be spontaneous descent. So we don't operate till 6 months. So here immediate orchidopexy is out, wait for 2 years is out, wait for spontaneous resolution is out. Because there is bilateral undescended testis, there is a role of giving GnRH injections. But this is only when there is bilateral undescended testis, not in unilateral. So in bilateral we give GnRH and we wait for 1 month. If it does not occur, then we carry out surgical treatment. That is the correct answer. So for orchidopexy, we do it at 6 months of age. A 40-year-old male comes with a testicular swelling and another swelling over the umbilicus and the right supraclavicular region. What is the most likely diagnosis? So 40-year-old male has a testicular mass, an umbilical lump and a right supraclavicular lymph node. So these are all signs of a testicular tumor which has metastasized, The atypical presentations, we know Virchow's node or Troisier's sign is Virchow's node or Troisier's sign. This is left supraclavicular lymph node. This is left supraclavicular lymph node, or left supraclavicular lymphadenopathy seen in any GI or advanced urological malignancy is a sign of advanced disease, and this left supraclavicular lymph node is suggestive of Troisier's sign. And the nodule over the umbilicus is known as Sister Mary Joseph's nodule. These are the atypical presentations. You can get an Irish nodule, that is left axillary lymphadenopathy. Migratory thrombophlebitis is commonly seen with pancreatic cancer. Bloomer's shelf is when you have metastasis in the pouch of Douglas. And Krukenberg's tumor is when there is bilateral ovarian metastasis. These are all atypical presentations which you should know of. So the next question is that a 50-year-old male feels heaviness in the scrotum. He is suspecting carcinoma, so he comes to the OPD. There is no pain and transillumination is negative. So what is the diagnosis? So this is a question of elimination, right? So there is no mass, so tumor is out. There is no pain, so torsion is out. And there is no transillumination, so hydrocele is out. So this is a case of varicocele, where the patient has dilated tortuous, where there are dilated tortuous pampiniform plexus of veins. The dilated tortuous pampiniform plexus of veins, and this can give rise to heaviness. Patient can come with heaviness, and this can also give rise to infertility. Now, one classical sign which they did not mention here is when you palpate this, you get a bag of worms consistency. Had they written that, it would have been a very easy question. When you palpate it, you get a bag of worms consistency. Three testicular appearance is seen in patients with spermatocele. Spermatocele is when you have a collection of fluid in the epididymis. This is known as spermatocele. This is a collection of fluid in the epididymis, and this is transilluminant as well. A male patient with a history of smoking presents with blackening of the index finger. So blackening means there's gangrene, and smoker, they've given a very big history of male patient and smoker. This is typically seen in Berger's disease. Berger's disease is also known as thromboangiitis obliterans. Berger's is also known as thromboangiitis obliterans, and this involves the small to medium sized vessels, and this can give rise to gangrene. Atherosclerosis usually involves the larger vessels. And Raynaud's phenomena, which was asked last year, you know that here you get white, blue, red. So because of vasospasm, the color change will occur in the hand, and initially the hand will be white, then blue, then red. So that is the color change that has also been asked in the exam. This was a repeat question. A 50-year-old female underwent an orthopedic surgery of the right lower limb, and she was bedridden for 3 days. After 3 days, she develops breathlessness when she suddenly starts to move around, and she is brought to the ER. So you know, when the patient is bedridden for a long time, the patient can develop DVT, deep venous thrombosis. This is common when you do orthopedic surgery as well. So deep venous thrombosis can develop, and because of this deep venous thrombosis, there can be a venous thromboembolism which can occur, which is very common, which is why we use mechanical prophylaxis like DVT stockings, are used, or we can use pharmacological prophylaxis like low molecular weight heparin. Which of the following is the investigation of choice for pulmonary thromboembolism? So the investigation of choice for pulmonary thromboembolism is CT angio. This is the investigation of choice, whereas pulmonary angiography is the gold standard. But because pulmonary angiography is an invasive technique, this is not done. What is usually done is CT angiography. D-dimer is also raised in these patients, but the investigation of choice is CT angiography. What is the cause of cannonball appearance in the chest X-ray? You can see this cannonball appearance is usually seen when there are lung metastases. These can be lung metastases from testicular tumor, or it can be lung metastasis from renal cell carcinoma, and that can give rise to this cannonball appearance. The final question was that what is the preferred treatment for the condition shown in the image? This again has been asked previously. This is a dermoid cyst, and this dermoid cyst is seen at the lines of embryonic fusion. Lines of embryonic fusion. And this can commonly be seen in the outer canthus of the eye or in the post-auricular region. So post-auricular region or outer canthus of eye is the most common locations, and we have to carry out surgery. But before we do surgery for this patient, we should always rule out intracranial extension. Always rule out intracranial extension in these patients. So these were the 45 odd questions which were asked in surgery. Again, as I've told you, that repeat questions are asked, so you should definitely go through these before your exam. Also, this would give you an idea regarding which are the important topics to prepare from surgery, and you should lay more importance on them. If you have any further queries regarding these questions, please post them in the comment section, or you can contact me on my Instagram ID as well, which is left-handed surgeon. If you like the video, don't forget to press the like button so that it reaches out to many more students, and do subscribe to my YouTube channel because I keep on posting important questions and important topics for FMGE students. Thank you very much.